Well, hello and welcome to today's Lunch and Learn series and happy Heart Failure Awareness Week. Our topic for today's feature is social determinants of health and heart lessons from the field. My name is Kelly Macheska and I'm the Senior Programs Manager for Heart Failure, and I'm part of the Quality Research and Analytics team at the American Heart Association. Before we get started today, I have a few housekeeping items just to go through as we cover today's event. This Lunch and Learn series is going to be recorded and it'll be sent out in the next 24 hours. Today's presentation can also be downloaded in the handout section of your GoToWebinar. And we will also be sending out a recording and handouts tomorrow as well. All dial-in participants will be muted to allow speakers to present without interruptions. And we will have the opportunity to submit questions by typing them in the questions pane of the control panel. We had folks yesterday raise their hand, but we definitely suggest typing them in, and that way we can tally them throughout the call today. And the team will go ahead and collect those, and then at the end of Dr. Williams's presentation, we can go ahead and pose the questions to her and try to help answer those the best of our ability. I would like to introduce our speaker for today. Her name is Dr. Connie White-Williams. She is the Senior Director of the Center for Nursing Excellence and Heart Failure Transitions Care Services for Adults at the HRTSA Clinic and an Interprofessional Collaborative Practice Clinics, who cares for underserved patients with heart failure at UAB. She is also a joint appointment as an associate professor at UAB School of Nursing, and Connie has a field of heart failure. She's been in the field of transplantation for over 35 years, so brings us a lot of experience and knowledge. Her research interests include quality of life and outcomes in heart failure and heart transplants, and healthy outcomes in underserved patients with heart failure. So at this time, I'm going to turn it over to Dr. Williams. Please give her a warm welcome. Thank you.
Well, thanks everyone. I'm excited to be here with you today to share a little bit about our experience from our clinic, and hopefully you will learn a little bit more about social determinants of health, which is a hot topic, and how it impacts heart failure. There we go. So we're going to talk about what social determinants of health are, and then we're really going to talk about those downstream effects, and those are the social determinants that hit us when we are in clinic with our patients. And so let's just start off with that basic definition of what social determinants of health are. And the WHO describes those as conditions in which people are born, grow, work, live, and age. And really it's about what those conditions are that impact our daily life from day to day. The components of social determinants of health are comprised of several different areas. And we're going to talk about some more than others, but all of these can impact our healthcare outcomes of our patients. The first is housing and neighborhoods. So it's important to know, does your patient have housing? Do they live in a safe neighborhood? Does their neighborhood have street lights? Do they have sidewalks? Do they have a park nearby where they can exercise? So all of those are very important to outcomes with our patients. Education is also important, and it's not really just did they graduate from high school, but we're also talking about health literacy. And does the patient have the ability to navigate the health system in which they are being seen? Socioeconomic position is comprised of many different components. Mainly for us, when we see our patients, it's looking at, do they have an income? Do they have a job? Do they have insurance? And then all of the other things that go along with being able to get them in a position to take care of themselves. The other portion is transportation. Do they have the means to get to clinic appointments? Do they have the means to get to pharmacies to pick up their medicine? So do they have a car? Do they have access to public transportation? And if so, do they know how to use the public transportation system to get to areas where they need to go? We're going to spend most of our time on the next three components. The first one is food insecurity, access to medicine, very important to our patients with heart failure, and then access to care, giving them the care that they need to take care of themselves when they have heart failure. So let's talk about social determinants of health and the impact. We usually put social determinants into three buckets. There are upstream social determinants of health, and that is when we see laws and policies to address community conditions. So this is where our lawmakers, our councils, our mayors of communities get involved to change the condition of the area and the environment. We need help to get those sidewalks, and we need help to have a safe and clean environment. So we really do need those policies and policy makers to help us with those. The midstream social determinants is a little bit where we come in, and we need to assess patients for their needs. And a big shout out to our social workers who really help us by identifying social determinants of health with our patients, by using screening questionnaires and addressing perhaps problems before we get to this downstream effect. But what we're going to talk about today is those downstream effects, and those are that trickle down issues that happen because those upstream and those midstream social determinants have not been addressed. And it's what we see when we see patients in clinic. So when we look at social determinants and their impact, we've learned that 60 to 80% of health outcomes can be attributed to social determinants. And we really found from the REGARD study that it really isn't a cumulative effect. If you have one of those social determinant components, it really can impact your survival after in initial heart failure admission. So it's really important to address social determinants when you see patients, whether they're in the hospital or in clinic area. And we know heart failure is expected to increase in incidence, and it's a very costly chronic condition. And we also know from research that transitions of care are so important, and there's so many components of transitions that can be impacted by the consequences of social determinants. They can be challenging, the lack of transportation, the economics, the not having a primary care provider to go back to and get follow-up care. So many different things can really take a wrong turn when we are looking at heart failure. So important to address those social determinants in these patients. So we're really going to look at these three areas the most today: access to care, food insecurity, and access to medication. And we're really going to talk about maybe some ways that you might be able to help patients in your own areas. I'm just going to give you some examples of what we do in our clinic, and perhaps this can be taken home and you could help patients in your areas. So I think the first question that we often ask ourselves is what happens when patients don't have access to care? And we found this in our own area in that, yes, they don't have the follow-up that is needed for heart failure. They aren't titrated on their guideline-directed medical therapies. They might not get the interventions that they need. But what we found in our institution is that our uninsured heart failure patients use the emergency department for their routine care. So when there was a problem, they went to the emergency department. It was either taken care of or they were readmitted for that problem. But then again, it's just a vicious circle because if they don't have any consistent follow-up, they just kept going back to the emergency department or kept going back into the hospital. But that transition was not done, and so it was just a vicious circle. And our clinic started to see if we could prevent that from happening. So we called it the HRTSA Clinic, Heart Failure Transitional Care Services, but you could do anything in your own institutions, just looking at some type of a program to look and take care of underserved patients. We were fortunate. We started with a grant-funded clinic, so it was an academic practice partnership between our hospital and our School of Nursing, and we developed a interprofessional team that continued to grow long past the grant, and we are now sustained by the hospital because we were able to decrease hospitalizations and we were able to decrease costs pretty significantly in this group of patients. So we have nursing, social work, medicine, pharmacy, health professions, and public health all in one area. So it's our clinic and our office spaces all together, and we work together to take care of these patients. And our goal is really to get them on that guideline-directed medical therapy, get them on their maintenance doses, address the social determinants of health so that they can take care of themselves. And we do that by engaging them in their own care, helping them with the resources that they need so that they can navigate their own self-care management. So we'll take an example of a patient and we'll talk about this patient through the presentation. Mr. J is a 59-year-old African-American male. He presented to our clinic for evaluation of his heart failure. And as you know, usually heart failure patients do not just have heart failure. He had a long history of hypertension, chronic kidney disease. He did have some cocaine use, and he was smoking cigarettes. And then he had a recent stroke, but he did not have any issues from that and recovered just fine. When we reviewed his medical records, he'd been in and out of the hospital, but had 4 documented ED visits with hospitalizations just in the last 6 months. So he came in and with chest pain and shortness of breath, some elevated blood pressure, and he stated in the records, I didn't take my meds because I wasn't sure which ones were important enough to take and buy first and when to take them. So he became short of breath with walking 10 feet to the mailbox, whereas he was able to do that without issues. He doesn't have current chest pain, but he does not exercise and he does not adhere to any healthy diet. He is unemployed and he's uninsured. And he told us that his home was bulldozed and that he's living with his sister. So he really doesn't have stable housing at the moment. He does have a history and reports current tobacco and cocaine use. His depression and anxiety screens were low, but his health literacy screen was inadequate, and he did screen food insecure. So how we go about addressing social determinants of health in our clinic, we actually do 3 bundles of care. We first look at that transitional care, and so that is going to meet the patient, hopefully before they're discharged, to introduce them to us and our clinic and the team. We call these patients a lot to remind them of their appointment, and we also used text messaging system. We offer a home visit if they are within a 30-mile radius of the hospital. And we did suspend this during COVID, and we're hoping that we'll be able to resume in the upcoming months. And then we make that interprofessional team appointment. So they're seen by everyone on our team, and we really begin to establish that trusting relationship, which has not been their experience in the past because they didn't have a relationship. They didn't have a medical home that they could depend on. We do, as I said, our goal is to get them on the medical therapy that they need, and we do that by having a pretty extensive access to medicine program, which we're going to talk about coming up. But I think one of the important things that is unique about this clinic is that we do not bill for our services. We are totally sustained on our ability to keep patients out of the hospital and save our hospital costs. We also do that extensive social determinants of health assessment, which really is looking at all of those components and really trying to decide and prioritize which one needs to be done first. And it's all about helping them take care of themselves afterwards, because it's about that patient activation. What can we do to help them better take care of themselves? How can we engage them? So many times it's providing them with the resources. We have scales, blood pressure cuffs, pill boxes to help them with their care. And then as we see them in multiple visits, we start really working towards getting them on that maintenance dose of drugs, and then doing what I'm going to call the more time-intensive and difficult social determinants. What if they do need housing? What if their environment is safe? Those types of things. So those sometimes take a little bit more time and some partnerships with our community to get those to where we need them to be. We also offer behavioral health services, and I'm going to talk about that in just a little bit. But I did want to spend a little bit of time on food insecurity, which is an economic and social condition characterized by limited or uncertain access to adequate food. And COVID-19 has really impacted food insecurity in our country, with 40 to 54 million people who are food insecure. And Feeding America projects that 42 million, or 1 in 8 households, are food insecure, and that racial disparities exist with food insecurity. So in our clinic, over 58% of our patients are food insecure, which is much higher than in our state, 19.2%. And perhaps it's because every patient that we see in clinic, we do a screening with a validated 2-item screener. It's called the Hunger Vital Sign. And we ask them, are they worried about having their food run out before they can buy more? And We also asked if the food we bought didn't last and we didn't have money to get more. So those are the two screening items. And of course, any positive response would indicate that the patient is food insecure. So what we do for food insecurity is we do have some meal vouchers. We work with our care transition department, and if somebody is in immediate need, and we've seen patients that come with they've gone a day or two without eating, we will give them a meal voucher to our cafeteria so that they can go get a meal before they leave. While it is now on hold, but we do have a support group once a month. We provided a meal for that support group, and we found patients loved that, and they are anxious for us to restart those. We did have to put them on hold due to COVID. But we partner with our local food bank. So it's the Community Food Bank of Central Alabama and our benevolent fund. And we are able, for every patient who is insecure, we can provide a bag of dry goods and a bag of seasonal fresh produce. And we are able to do that every time they come to clinic. And so this food usually can last them and maybe a family of 3 or 4 for about a week, maybe stretching it a little bit depending on the availability. And we get the food, and it really depends on what the food bank has during that time. So we have found that addressing the food insecurity has really helped us be able to manage their heart failure, because it really is very, can't think of the word, it's a good relationship that we found with research, that those who are food insecure are more likely to ration their medicines. Maybe they skip their doses, or they don't take their full dose to make it last in order to buy food for their family. Many times they could also use the emergency department because you can get a meal there, or you might get readmitted where you can get a hospital meal 3 times a day. So if we can address one thing, we might be able to really help multiple areas of heart failure care. So another critical piece of social determinants, of course, is medicine. And our goal, as I said, is to get these patients on their heart failure regimens and hopefully get them to they're stable in taking their meds. So how do we do that? There's a lot of education that comes into play, just similar to probably what you all do in your organizations. Every patient has a medication reconciliation, and we use an education program called Medicine Action Plans. So it actually has a picture of the medication, how many times they should take it, and what that medication is for. And we found it really does help our patients. And so every patient leaves with an updated plan before they leave the clinic. We do give the pill boxes, and we also, for those who have difficulty filling their pill boxes, we will fill their pill boxes for them. So our nurses in clinic get, sometimes we do 2 weeks at a time, so 2 pill boxes, or maybe even a month, and the patients actually use those, and then they come back every month or so and we refill those pill boxes for them. And then we educate them on their prescriptions and refills. It is amazing how many patients don't understand how to do a refill and when you should do a refill. So a lot of education goes into play with access to medication. We provide bus passes and educate them on their bus route to get to our clinic. And then we do provide, we've worked with the hospital, and they are letting us provide free parking. So for any patient who does have a car, that is able to happen. And then, of course, we rely on many assistance programs. So doing any of the free or low cost prescriptions with our local pharmacies and any kind of coupons, but we do rely on medication assistance programs. And for many of you, I'm sure you use pharmaceutical assistance programs, and every PAP has their own criteria for patients, and so every drug company uses something different. So you can go to the needymeds.org and look at all the PAPs that are available, and we do many PAPs, hundreds probably a week. And so we actually have a dedicated position, someone with a public health background who assists our social workers with these applications. The other thing we have, which maybe you aren't as familiar with, is a Dispensary of Hope pharmacy. So the Dispensary of Hope Pharmacy is a charitable medication distributor that provides pharmacies and safety net clinics free medications for their patients. Patients must be at or below the 300% federal poverty guidelines, and there are some rules that you must follow. So we partnered with our ambulatory pharmacy to implement this back in May of 2019. There are some annual dues that you have to pay to Dispensary Hope. The medicine that you receive must be stored in a separate area, so it cannot be intermixed with the pharmacy's medications. And DOH has its own formulary, so not every medicine that you might need is on that formulary. But we have subscribed or prescribed in the time that we started from May of 2019 to present, over 16,000 prescriptions. And this number of savings has gone up, and we're well over $1 million in savings to the hospital, because if these patients weren't getting these medicines, we might be having to high risk these patients and use hospital funds to get them their medicines. So a few other things that I want to go over quickly, because I do want to leave time for all of you to ask some questions, but things that we help our patients with regarding housing, socioeconomic position, and education. We do collaborate with our community partners and local organizations, and they are very instrumental in helping us find housing that is in an environment that is safe for our patients. And so if you are in need, and I'm sure every place has their own community partners, but this has been very rewarding for us to be able to find someone safe housing. We do utilize our women's shelters and behavioral health to help us with that also. As I said multiple times, I can't emphasize enough that transportation is such an important component, because if they don't come to clinic or they don't go to the pharmacy, it really is a barrier to their successful care. We do assess for health literacy, and we make sure that the educational material that we use matches what they're able to understand. And then for folks who have not graduated from high school, we do help them get enrolled and try to obtain their GEDs, and just helping to navigate health systems. This place is a big old place, and it's not always easy to find your way. And so getting them comfortable with us and others is really important. We've been real fortunate to have our partnership with our School of Nursing, and we are in the last year of our behavioral health integration grant. So that grant has brought us a licensed independent counselor, social worker, and a psychiatrist to help us with patients who need some behavioral counseling. We partner with our Center for Psychiatric Medicine, who has a peer support program. This peer support program is trained personnel who have recovered from their addiction, and they come and they counsel with patients. They meet them where they are and help them through their journey to recovery. It's a small program, but it has been so rewarding because it's really been successful with our patients. And then we have hired a psych mental health nurse practitioner as part of our sustainability plan. She's just part-time, but I'm hoping that we can increase her time once the grant is over. So what happened with Mr. J? So we set him up with our DOH pharmacy, and so we were lucky and we got all his medications that he needed for no cost. And we are doing his pill boxes, so he comes back every 2 weeks, and we're actually now since this slide has been done, we've really been teaching him how to do his pill box, and he is totally on his own and able to fill his own pill boxes. And then, of course, we provide that medication action plan so that he understands those doses and the times he should take his medicine. We were able to provide him with food for those immediate food resources, and then our social workers were actually able to get him some state benefit programs to help secure food in his local area long term. He's been undergoing counseling to help with the smoking and substance abuse, and he did, as I said, take us up on the peer support and behavioral health counseling. So with the social works assistance, we were able to apply and get him approved for supplemental security income, and so he actually got some monthly income, and he was able to secure some stable housing. He is working towards that tobacco and substance abuse dependence, and we're getting close to him being recovered. And we actually, during the time he was in clinic, we were able to have some physical therapy students in our clinic who actually got him enrolled in cardiac rehab, and he completed that rehab. But most importantly, he has had no emergency department or hospitalizations in the last 12 months. He was able to resume some fishing, which he loves to do, and he reports New York Heart Association Class 2 symptoms, which is an improvement from his initial visit. So this is an N of 1, but it is such a success story for us because it does feel good at the end of the day that we have helped our patients with their heart failure. So a few take-home points that I'd like to share. This interprofessional collaborative practice that we started, we really do believe it can be a successful model, particularly in the underserved population. We really need others to replicate this model so that we can do further research to see really why this works, and make sure that what we're reporting is true anywhere. Addressing those social determinants of health clearly can lead to improved heart outcomes, and we just need perhaps to think about the tool that we use. I'm sure all of us are using something different. So a standardized assessment tool so that we can also continue to do research on perhaps the importance of identifying and intervening with social determinants. We know from our experience that we can reduce hospitalizations, and we can have significant cost avoidance. These patients wouldn't be paying anything. They're underinsured, they have no money. So by keeping them out of the hospital, it's that cost avoidance that we are contributing to our organization. And then I think also importantly is patient engagement. How to engage patients in their own care is so critical, and it's important to all of our missions of keeping our folks out of the hospital. And with that, I think that ends the presentation, and I will be more than happy to answer any of your questions.
Thank you so much, Dr. White-Williams. This was just an incredible presentation and how impactful this is for your patients. So thank you so much for sharing. We did get quite a few questions coming through, so I'll start with a couple here. And there's been a few that relate to the financial model. If you wouldn't mind expanding on that a bit, just on if you bill at all for like a transitional care management appointment, and then the financial resources for not just the visit services, but the tangible items for patients, like the blood pressure cuffs, scales. If you could just share a little bit more about that.
Yes. So, and this is the challenge with this model. So I will be very transparent. It's a tough model to sell, but we do not bill at all. We have worked with the health system, so all the labs that we draw are not billed for. We do not bill, our nurse practitioners do not bill for their services. Now, the caveat for that is if we don't show that we can reduce the cost and the hospitalizations, those are things that we always have at stake for our sustainability. As far as blood pressure cuffs, scales, pill boxes, we have been able to get a little bit of grant funding, and that helps us to be able to purchase those. And if we didn't have grant funding, it is something that we budgeted for within our clinic budget for our patients.
Great, thank you so much. Going back to, you talked about the Dispensary of Hope program, and someone asked if this is just if the Department of Health dispenses that to the clinic, or if it's dispensed directly to the patient. Can you explain a little bit more about that process?
Yes, and you all can go to dispensaryofhope.org or Google it, because it is a national distributor, so anybody can participate in the Dispensary of Hope. And what happens is once you set up that fee, and we have a contract with them. We have the formulary, so our pharmacist helps us, and we actually order the medicines that we use the most in clinic. And so we send that order to the Dispensary of Hope pharmacy. Then that medicine comes to our pharmacy, and we have a specific mechanism in which our providers order and prescribe that medicine, and we work with our pharmacy. So it's really, it took us a minute, but it's pretty seamless right now. So we just have a system. Now, we haven't expanded it past our clinic, except for we also have a School of Nursing run diabetes clinic that does similar work to ours, and they just started using Dispensary of Hope just a couple months ago. But anyone can do this. You can just go and look online, and I can't say enough how wonderful it is, and it's been truly helpful for us to get medicines for our patients.
Thank you so much for sharing that information. We had another question come through. If you could talk a little bit more about the health-related social needs assessment that you do with your patients. You mentioned that it's a pretty in-depth, thorough assessment. Is there a standard screening tool that you use? Is there one that's out there that you recommend? Can you talk a little bit about that, and also how often you do it?
Yes. So we actually have developed our own screening tool, and it is in our electronic medical records. Our social workers and myself worked to try to get all of those components. So we really try to hit on everything. And I'm not saying that it's where it's the one that everyone should use, but I do think that it does help us try to identify all of those needs. And there are so many other tools out there. In fact, our inpatient area uses the Prepare assessment tool. And that's actually a very good tool. We like components of that, but we were actually wanting a little bit more for our assessments. So I think that's an area of research. And I know American Heart Association is looking at that tool. Maybe we would develop something that could be used in multiple areas, and that's just a need that we have, because it would give us so much more information if we were all using the same instrument.
Great. Thank you so much, Dr. White-Williams. This was, again, such a great presentation. We did have quite a few other questions that we won't be able to get to, but if you're okay, we'll follow up with you, and then we can send a follow-up to the participants with the questions we weren't able to answer.
And you are all welcome to email me also, but I would love to be able to answer all your questions.
You're amazing. Thank you so much. Thank you again to our presenter for such a fabulous presentation today. Thank you to all of you for joining today and for your great questions and engagement throughout the presentation. We will send a follow-up to those questions that we were not able to get to. We'll also be sending a recording along with the slides for today. And we hope that you'll continue to join us for the Lunch and Learn series throughout Heart Failure Awareness Week. So thank you again, Dr. White-Williams, and thank you all for attending.
Thanks, everyone.
Thank you.